Hello everyone and welcome to our Michigan Medicine Live event. I'm Ed Bottomley with the Michigan Medicine Department of Communication, and today we'll be discussing bariatric surgery. What makes someone a good candidate, what to expect before and after the procedure, and more. So let's meet our experts. Over on the far end we have Dr. Nabeel Obeid, a bariatric surgeon, and he's also leading Michigan Medicine's bariatric program in Chelsea. So we're going to talk more about that new location during the course of our chat. In the middle, we have Alex Kennedy. She's a dietitian, and she works with patients before and after surgery to address the nutrition aspect of the program. And next to me, we're also pleased to be joined by Christina, one of Dr. Obeid's patients. Christina had bariatric surgery, and she can speak more about the actual patient experience as well. Just a reminder, you can submit your questions at any time, even now, for our panelists to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on the video, but please note that if you do comment, your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can also send a private message to us via Facebook. If you can't stay for the whole chat, or want to share the recording with a friend, a video of this chat in its entirety will be on the Facebook page, and it will also be posted to the Michigan Medicine YouTube channel shortly after that. So let's get started with our first question. How do I know if bariatric surgery is right for me? Can you be too healthy or not healthy enough for bariatric surgery?
I think I'll start that off. I think that question's best answered from sort of multiple perspectives. From a medical surgical perspective, there's certain things that a provider may want to know more about when interviewing a patient in their initial consultation. But I would say there are some relatively fixed guidelines in who qualifies for bariatric surgery in terms of is someone medically fit for surgery. That's a determination that we make at their initial consultation. So my advice is if you're thinking about it or interested in learning more, easiest thing to do is just to call our program and we can, set you up with an initial consultation or guide you further. But there are some medical things, whether it be patient's medical history, types of medications that they take, previous surgeries, that may determine, how well they may be a candidate for the operation.
Thank you. The next question that we have moving on from this, how do you determine a good candidate for surgery? Alex, how would you determine a good candidate for surgery from a lifestyle, behavior, dietary standpoint?
So when we're first evaluating patients for surgery, there's a few things that I kind of look for and evaluate, and the first being a willingness to change. So there's a lot that goes on. It's not just surgery alone. There's a lot of lifestyle, social things that change. And so patients have to be willing to kind of change things in their lives. So that's the first thing. And then also I'm kind of evaluating for like a baseline knowledge to see, have people tried weight loss things in the past? Some people come in, they know the calories and everything, or they've done Weight Watchers and they know this has 8 points and this is a carb and this is a fat. So I try to kind of evaluate and see where the patient is at. So that's pretty much what I look for initially.
Dr. Obeid, you touched on this a tad. How do you determine a good candidate for surgery from a surgical perspective?
Well, there are certain conditions that may make the physical act of performing surgery very risky or basically not an option in certain patients. If someone has had previous stomach surgery, for instance, that may alter the types of bariatric procedures that may even be an option for that particular patient. Very severe medical conditions like heart failure or advanced kidney disease can pose certain challenges in taking care of patients. But having said that, we treat patients of all sort of the spectrum of medical complexity and previous operations. So again, it really comes down to a detailed history taking and examination with the patient to determine sort of what those factors might be that helps us make that ultimate decision.
Sure, indeed. The next question that we have, does type 2 diabetes make my surgery riskier?
I would say the answer to that is no. Probably 40 to 50% of our patients are diabetics, if not potentially more. And so this is a very common condition that's associated with obesity. Traditionally, obesity and diabetes are risk factors for certain things like wound healing, but because we do these procedures laparoscopically, which means with small incisions in the camera technique, there really aren't many wound complications related to this operation. And because most of our patients are diabetics, we've been able to demonstrate that we can do this operation safely.
Thank you for that. Will I be able to stop taking my diabetes medicine after surgery?
That's a great question, we can go down the panel to get different people's takes on it. So in general, bariatric surgery, which is a metabolic operation, so one thing I like to point out is it's much more than just a weight loss surgery. I talk to my patients about the fact that there are significant metabolic changes that occur with this operation, and so I actually don't like to refer to it as a weight loss surgery. One of those conditions being diabetes, in that it significantly improves after the surgery. And some of these conditions, diabetes, sleep apnea, blood pressure issues, cholesterol, reflux disease, many of them get better or improve to a certain extent independent of the patient's weight loss, meaning that they may see results in improvement of their health even before they've reached their maximal weight loss. And diabetes is no exception to that. In fact, we do have patients who routinely leave the hospital with potentially up to half of their previous dose of medications going into surgery, and then leaving the hospital with half to maybe even none of the medications that they were taking before in order to control their blood glucose. So it does have dramatic effects. Now, that's not the same for every patient. So to answer your original question, is everyone going to expect to be completely off diabetes medications? Not necessarily, but you can expect that you'll have a significant improvement in your diabetes control, and most likely a reduction in the dosage of the medications that you take.
Great. Anything to add to that, Alex?
No, I definitely see that. I mean, when I see patients at 2 weeks after surgery, a lot of them are significantly reduced in their medications and they're already feeling better. They are all on a pre-surgical diet, which I think also helps to kind of helps with the insulin levels and all of that, but it's pretty exciting to see.
But Christina, perhaps we could get your perspective on this too.
So actually, I was pre-diabetic, so I hadn't taken any insulin. I wasn't worrying about that. But once I had the surgery, they tested my A1C, and it went from, I believe I was at a 6, and now I'm at like a 4.9. So I mean, it really changed the whole game. So it was nice to no longer have to worry about that.
Indeed.
I actually had a question that I just thought about that we get asked a lot, kind of related. A lot of patients will say or ask, if I can lose weight on my own, why would I go through surgery? And I think the point that you said about it being a metabolic surgery is huge. So I think with traditional dieting and trying to lose weight, a lot of people are up against hunger. They're battling that constantly. So, or they can't feel full or things like that. So not only does surgery provide some sort of built-in portion control, but it also provides these amazing metabolic benefits of just the insulin and regulation and also hunger hormone regulation. So feeling full and not, craving certain foods, those kinds of things is a huge benefit of surgery. So.
Thank you for that. Mm-hmm. The next question that we have, how soon can health conditions improve after surgery?
So, as I alluded to, it can be as soon as a few days following the procedure. In the case of things like glucose control, some things take a little bit longer, a few weeks, maybe even months or years until they manifest. Very common conditions that improve relatively quickly after surgery include, again, diabetes. Obstructive sleep apnea is a big one, and it's a common one among our patients. Many of them find that their settings on their CPAP go down significantly within a few weeks of surgery. They can feel the difference. They're getting a better night's sleep. feeling energized and rested when they wake up in the morning. So those are, and again, that can be independent of their weight loss. So it's something that's seen relatively quickly after surgery.
And the next question that we have, this is something that you touched on just a bit. How are sleep and weight loss related?
Sleep and weight loss?
Yeah.
So again, there are multiple factors associated with that. Obstructive sleep apnea is the main one, which is a condition that is not just related to the anatomy of the neck and the airway, although it's oftentimes felt to be mostly related to having a large, heavy neck that obstructs the airway. But a lot of good research has shown that it's much more than that, and there's a connection with the brain and sort of neurohormonal pathways that help to regulate that, which is actually why we think that that sort of condition improves quickly after surgery, despite the fact that the anatomy of the neck hasn't changed all that much. And so there are some more physiologic issues that can affect that, that frankly aren't completely sorted out in the medical literature to this point. But having said that, patients oftentimes feel that their sleep patterns, their breathing patterns, they're not abruptly stopping breathing in the middle of the night, something called apnea. And so, again, they feel much more rested and feel like they're energized for the day soon after the surgery.
Sure. Anything to add to that?
Yeah, and I think of it from the food perspective. So when people, wake up and they're super tired, they're usually reaching for, they make poor food choices and, a lot of energy drinks or sugary coffee drinks to keep them awake. And so throughout the day, maybe not making the healthiest food option can then lead to weight gain, which kind of starts this cycle of then affecting the sleep habits. And it's this, cycle that happens. So.
I was on the CPAP when I had the surgery, and then after every 10 pounds I would lose, I'd try a night without it. And my poor husband used to say that it sounded like I was sucking the paint off the wall when before I had my CPAP, because I was snoring so badly. And so I had my surgery in March. By June, I was completely off my CPAP. I sleep a good solid 6 to 8 hours a day, depending on how tired I am or if I've gone to the gym. I always feel very well rested, and the only time I have a hard time sleeping or breathing at night is if I'm sick. So now it's the most wonderful feeling to be able to sleep without that snuffleupagus mask on you. So it was really truly a great moment when I realized I didn't need that CPAP anymore.
That's great. Thank you for that. The next question I have: do I have to go on a diet before I get surgery?
Yes. Yes, there is no way around that. The diet is, most people call it a liquid diet, but there are a few things you can chew on the liquid diet. Typically it's 2 weeks long, sometimes up to 3 or 4 weeks, depending on medical history, and that's determined by the surgeon how long it will be. But that's what we're here for. We have patients, we follow patients pretty thoroughly, and take a class and learn all about this liquid diet, primarily made of protein shakes. But the purpose of it is to shrink the liver before surgery. It makes surgery a little bit safer, and then also help lose a little bit of weight before surgery as well. So, do you have any comments about the pre-surgical diet?
It's not terrible. I mean, honestly, it's something to get used to, and you're already invested in making this huge life change. Post-op, you have to put that time in pre-op. So it's kind of getting you used to what your meals will look like, or how to sort of get that discipline. The shakes aren't terrible. I mean, I certainly wouldn't want to have that as my first choice every day, but there's great chicken soup option. You get to celebrate at night with some veggies if you're going crazy. But it wasn't awful, and it's a really great way to sort of ease yourself into this huge thing you're about to do.
I'll add just one more thing to that. So Alex had alluded to the purpose of the diet, aside from kind of getting you in the rhythm into surgery and then to follow that post-op diet. The reason we do it preoperatively, in addition to shrinking the liver, which helps dramatically for the technical aspects of the surgical procedure, We have to be able to lift the liver up to be able to see and work on the stomach. And if patients have not been on that preoperative diet, the livers can be very heavy and very difficult to move out of the way. And so it makes the surgery a little bit more risky and less straightforward if that hasn't been done. And just to add to that, there have been some really good studies to show that doing that preoperative diet, which is, again, usually 2 weeks, but sometimes up to 4 weeks depending on patient factors, has been shown to decrease the chance of complications related to the surgery. So there are multiple good reasons to sort of recommend and mandate that patients do this leading up to the surgery.
Yeah, indeed. Thank you for all those answers on that, all those perspectives. The next question we have, will I have to diet or exercise after the procedure, and how long for?
Forever. So bariatric surgery is not a quick fix for weight loss. Obviously, it helps jumpstart it quite a bit for a lot of people, and there's what we call a honeymoon phase where people really feel the hormonal effects and the fullness cues, but and everyone's a little different, but typically that kind of wears off and people really have to start focusing on what they're eating, how much they're eating, and exercise, just as you would before surgery. So it is definitely a lifelong commitment to, not only lose weight, but then keep it off in the long term. Do you have any comments? I'm sure you do.
Yes, I wasn't a real gym rat or anything before, clearly not working out as much as I should, but now, I go to the gym 3 to 4 times a week. I go to a CrossFit class. I'm not a CrossFitter, but but it's activity, and I know when I don't do it, I don't feel well. I feel you can see the scale kind of move a couple pounds, and it's something that I know I will have to do for the rest of my life. But it's ridiculous, and I know that people listening are saying I'm full of garbage, but I swear you get addicted to that good feeling, those endorphins, that way that it makes you feel throughout the course of the day, and it becomes a part of your life, and it's so much better. I'd rather reach for my gym bag than reach for candy or pizza. So yes, it's something I know I will do for the rest of my life, and I'm pretty cool with that. So
the next question, if I have surgery and don't follow the diet guidelines, what will happen? Will I just gain weight, or will I get sick?
Potentially both. Initially, after, sometimes people will try to move too quickly throughout the diet. I mean, as the stomach is healing, it's very much liquids and then pureed and soft foods that and some people will move too quickly and they'll get sick. Their stomach can't tolerate it at that time. But long term, most people can tolerate pretty much anything without really getting sick. I think rare cases people will become ill after eating certain foods. But have you experienced any foods that?
I can't eat asparagus anymore for some reason.
Yeah, it's always a random food for
weird.
some people.
Yeah.
Like lettuce tends to be a big one for some reason, or really dry grilled chicken breast or things like that. But yeah, and it's different for everybody, but I think definitely, using us as a resource to kind of help people through the process.
Yeah, a couple things to add to that. So early on after surgery in the healing process, certainly patients can feel like swallowing foods, and particularly certain foods, feels quite different than it was before surgery. And very early on, even sips of water can feel uncomfortable or odd to the patient. And that's all normal as part of the healing process. The stomach is obviously integral to the swallowing and, the GI tract process for digestion of foods. And of course, when you operate on the stomach, you feel those effects, but it's certainly not a long-lasting effect in terms of the difficulties or the sensations with the swallowing. I will say with one procedure in particular, the Roux-en-Y gastric bypass, sometimes just referred to as the bypass, there is something called dumping syndrome, which can make you feel ill with certain foods. Generally, high concentrated carbohydrate, sweets can make you flushed and sort of ill. And so patients quickly learn to stay away from those foods because it can have a dramatic sort of side effect in that regard. But Yeah, and then just to comment on the asparagus and other things, it's very common for patients to have a complete change in their sort of taste buds, what's appetizing to them, at least for certain foods in particular. And most patients can identify that one or two things that they used to enjoy and they just don't have the appetite for anymore, or something that they used to not really find appealing is now something that they enjoy. So not really clear in terms of the science behind that change, but it's a common observation.
That's fascinating. Next question we have up. I don't like to / don't know how to cook. Can I stick to the nutrition guidelines if I mostly eat out or eat takeout?
That was your question.
I believe that it doesn't matter if you don't know how and you don't want to. You really need to learn how to cook. You're about to make a huge investment in your life. And for you to say, well, I'm not going to, or I don't want to learn how to cook, you're not going to be successful. You cannot go to a McDonald's and be like, I'm just going to order a chicken breast. It's too triggering. You're going to be like, nope, I'm going to have a fry. I'm going to have 6 fries. I'm going to have 40 fries, and now I've had a large. It doesn't make sense. You are putting yourself through a lot. You're doing a lot of pre-work, a lot of post-work. Your body's going through a huge change. Learn how to cook. It's not difficult. You can slap some chicken breasts in the oven at 325 for 45 minutes. Bob's your uncle. There you go. You've got food. There's YouTube. There's Food Network. There's no reason that you can't learn how to cook. So for me personally, I would say absolutely not. You cannot be successful if you're not going to take care of yourself in your home every day and learn how to do that.
And I completely agree with that. I do, like 100%. But I do think now we live in a time where a lot of people are focusing on health quite a bit, and I think restaurants are taking note too. So I do think there are several options at restaurants. But what I like to do is teach people to be knowledgeable of nutrition so that they can go anywhere and figure out what they can order and still be on the plan. So it's not like you have surgery, your life ends, you can never go out, you can't, socialize. There are options places, but just kind of knowing what to ask for, how to ask for it. So that's kind of the perspective I come
Agreed.
from.
I mean, yeah, I'm not like, I don't
I didn't
hibernate.
mean
Yeah, no, I'm not saying, I don't hibernate. It's not like I never go out and do anything, but I think when people are thinking of convenience, and
Totally.
you have to learn. You've got to put the time in. You're already making yourself a priority. Make it a bigger priority. Cooking is one of them.
And on that note too, a lot of people think that healthy food has to taste bland or like air. It doesn't. There are so many amazing websites and recipes where you can use herbs and spices and make healthy food taste really good. And again, that's kind of what we're here for, to help with that. It doesn't have to be gross. Or just like chicken slash.
Right.
I was like picturing that.
It's just a thought.
I know.
I appreciate those answers a lot. Next question, can I drink alcohol after having surgery?
Well, I'll say just from a purely surgery / anesthesia standpoint, we certainly want to avoid that in the early postoperative period. But taking that a step further, it's really not recommended to engage in ingestion of alcohol for probably at least the first year. There is some interesting medical literature that one of the unintended consequences of bariatric surgery for some people who might be at risk is dependence. And so we take that very seriously, and we don't want patients to fall into a certain trap or develop these poor coping mechanisms or habits that end up becoming a serious problem, for their mental and physical well-being down the road. So that's a pretty serious recommendation that we have in our program. Be curious to see what other people think.
Yeah, we in our initial evaluations, we always talk about alcohol. I mean, from just a nutrition standpoint, it's empty calories. It hits the bloodstream really fast, so people often become very cheap dates. They'll before surgery, they can kick back, 3 glasses of wine, and after they're a couple sips in and they're feeling it, which then I think kind of relates back to the dependence is when people, turn to food for any sort of coping, they can then turn to alcohol, and it hits them pretty quickly. So, but we just say to stay away forever as long as you can. On special occasions, okay, but really trying to be mindful of that.
I've recently had an issue with this, and it's not great. I found myself through the holidays and sort of after, with some changes going on with my husband's work, and I think I celebrated too much through the holidays and sort of kept that train rolling. And I recognized rather quickly, along with the help of my therapist, that I was starting to sort of swap out my addictions, because obese, I'm a food addict, and this was, so now new coping. So I have stopped drinking completely. I haven't had a drink in about 45 days. It is really, it's hard to admit that, but it happens. And, without the help of my family or my therapist, I'd probably be injecting heroin in my eyeballs. But, it's something to be really aware of. And, as long as you're paying attention and you're seeking the help and you're talking about it and you're getting it out, you'll get there.
And I think now that we know that it can happen after surgery, we have resources and people we can refer to if patients ever are thinking like, I think I'm drinking a little more than I used to. So we always recommend, talk to us about it. It's not something to be ashamed of.
Absolutely. Absolutely. Thank you for those answers. Next question we have up, can I eat the same day I have surgery?
I guess if you wanted to get very sick, you could, but no, we do not recommend that. Usually day one is pretty much just focusing on fluids, just trying to prevent dehydration the first day. And then once you're home, we kind of educate all patients as far as the diet transition. So like I mentioned earlier, it's liquids for a while, protein shakes primarily, and then transitioning into pureed foods and soft foods, and then finally more regular type foods, which they're all different time points depending on surgery. But no, we don't recommend eating right after surgery.
Nor would you want to.
Yeah.
Let me just throw that out there. You have no desire.
Yeah. I think most people even struggle just trying to get the fluids in, just the way that
Sure.
they're feeling.
Yep.
Yeah.
The next question that we have up is with regards to energy levels. Will my energy levels change after surgery?
In my experience, most patients find that it does. Again, how fast that happens varies for people, but I think for a number of reasons it will. With the weight loss that's innate to the surgery, you will kind of feel like you have more energy and can get around a little bit easier. But again, in addition to improvement of other medical problems, that will increase your energy level. In addition to proper nutrition and following the dietary counseling.
Yeah. I think when I see patients, it kind of depends. Either at the 2-week visit, they're bouncing off the walls, they don't know what to do with all their energy, or they're kind of sluggish, and then by 2 months, then they're bouncing off the walls. But yeah, a lot of times it depends on sleep too. If you're, losing weight, sleep apnea, all of that kind of relates to how the person. But normally, everyone's different, but usually by 2 months, everyone's feeling great.
So we have a question just in through Facebook. We've been asked, when does being overweight signal a need for bariatric surgery? Do you have to have a condition like diabetes before considering surgery?
It's a great question. I'll answer it in 2 ways. The first is the strict sort of guidelines for who qualifies for bariatric surgery. And the second is really what the National Society is trying to move towards. But just so everyone's aware, most insurance companies will abide by the National Institutes of Health consensus guideline, which is dating back to 1991. And for that, it's a BMI of 35 or more if you have usually 1 or 2 obesity-related medical problems. or if your BMI is 40 or above, regardless of medical problems. And so those are the typical criteria for meeting eligibility for bariatric surgery. Now, to segue into that second part of the answer, we've recognized that patients with lower BMIs in that 30 to 35 range actually can benefit greatly from, again, metabolic bariatric surgery, not just weight loss surgery. And there are some really good studies, both nationally and internationally, looking at patients with BMI of 30 to 35 with diabetes and showing that they can actually reach diabetes remission in that group. So it's actually starting to become a topic of conversation, somewhat still controversial, but there's more energy and thought going into that in terms of potentially intervening sooner in that sort of BMI range.
I have a follow-up to that. What are some of the obesity-related comorbidities that would qualify?
Right, so the traditional sort of common medical conditions would be blood pressure, otherwise known as hypertension, cholesterol issues, obstructive sleep apnea, which we've talked a lot about, gastroesophageal reflux disease or heartburn, reflux, arthritis, very common musculoskeletal conditions related to stress on the joints, the hips and the knees. And then there's also mental health related disorders. You know, anxiety and depression are very prevalent in our patient population. So all these things are potential qualifiers for bariatric surgery and, more importantly, things that can drastically improve following the operation.
Next question that we have up, what kind of tests can I expect to take to get approved for surgery?
So that will vary based on the individual patient because no patient is the same as the next. Everyone is individualized, and that's how we treat patients in our program. We look to them as their own individual and customize their care accordingly. Certain conditions or medical history may warrant further workup. Just to give you a broad overview of the program in general, every single patient requires an initial consultation with our program, which is done in terms of medical, several domains, one being a thorough medical evaluation done by our physician assistants, and of course a thorough dietary evaluation and counseling done by our dietitians, as well as a comprehensive psychological evaluation. So all three of those are core tenets to the initial evaluations. Beyond that, a combination of recommendations based on those initial evaluations and after meeting with the surgeon will determine what additional tests are required. Some are medically necessary. For instance, if someone has significant heart disease, coronary artery disease, maybe they have previous stents in their heart from a heart attack in the past, we may want them to get a stress test or an echocardiogram or speak with their cardiologist to make sure that they're safe to undergo surgery. Patients get screened for sleep apnea. If they test positive for that, then we will recommend that they undergo sleep testing. Some patients who have reflux type symptoms may require an endoscopy, an upper endoscopy to further evaluate that. So it sort of depends. And unfortunately, aside from what we deem as definitely necessary, some insurances have their own requirements as well. So part of that, the answer to your question really depends on the patient's insurance.
The next question that we have up, Dr. Obeid, can you describe the different kinds of bariatric surgery available at Michigan Medicine?
Sure. So the two main what we call primary bariatric procedures, meaning that you've never had previous bariatric surgery, that we offer are the sleeve gastrectomy and the Roux-en-Y gastric bypass. Both of those are done laparoscopically, meaning with the small incisions and the camera technique. We'll start with the sleeve gastrectomy, which is the most common bariatric procedure performed in America today. It's about 60 to 70% of all bariatric procedures done across the country. What we do with a sleeve gastrectomy is In essence, we are trimming down the size of the stomach and leaving a long sort of tubularized stomach without rerouting the gastrointestinal tract. And the way we do that is during surgery, we have the anesthesiologist pass a sizer, which is basically a tube that is a particular diameter, so we know how thin or wide to be making the stomach tube. And by doing that, we remove the excluded part of the stomach. We remove it out of the body, and what you're left with is the food tube called the esophagus going down into the sleeve stomach, which is this tubularized stomach, and then into the first part of the small intestine. So again, the anatomy of the GI tract is not altered in that regard, but the size of the stomach is made smaller. And there are multiple reasons for why that works. Part of it is a mechanical reason, sort of oversimplifying it. You make your stomach smaller so you can accommodate less food and you feel full with less food. But there's really a more sort of eloquent, dramatic component to it, which is a neurohormonal component. Part of the stomach that gets removed is the part of the stomach that is involved with hormones of the gut related to satiety or feeling full, hunger, and it's the part of the stomach that communicates with the brain. And so there's a pretty sort of in-depth hormonal componot to this as well. The Roux-en-Y gastric bypass, again otherwise known as the gastric bypass or bypass, is a procedure that's been around for decades and a procedure that works quite well. In contrast to the sleeve, it does alter the anatomy of the GI tract, so we make the stomach smaller, called a gastric pouch, and then we reroute, we divide the small intestine and bring up a portion of that intestine to connect to that gastric pouch, and then reconfigure and connect things back together downstream. And by doing that, it allows for a lot of that hormonal effects as well. There are some good studies that show that the food bypassing that first part of the intestine has a dramatic effect on not only weight loss, but glucose control. So that's where improvements in diabetes can play a role, and other factors. Now, both procedures have their own sort of pros and cons, and that's a detailed discussion that you'll have with your surgeon when you meet with them. Depending on patients' medical comorbidities, meaning medical conditions, as well as any medications that might be taking, it can affect or sway the recommendation for one versus the other. And so that's a fair bit of information, but it's a good overview of what the different procedures are. Yeah,
that's great.
One thing I'll add to that, and maybe Alex can comment as well, is all patients require nutrition supplementation following bariatric surgery, and the regimens differ slightly based on the procedure that you undergo. Partly because with a gastric bypass, part of the nutrients that we ingest are absorbed in different parts of the GI tract, and when you reroute the GI tract, it can affect the absorption of some of those vitamins and micronutrients, et cetera. And so, the regimen is a little bit different based on the procedure.
Great.
Yeah. So, and you'll learn more about that. For bypass, like you said, vitamins and mineral supplementation is required for life. So that's often, it's not a temporary thing. Because the stomach is a little bit smaller, there's less enzymes to break down food. Not all vitamins and minerals are absorbed very well. So actually her alarm just went off on her phone to take her calcium.
Yep.
So,
Do that right after.
Perfect timing for the Facebook Live. The next question that we have, will gastric sleeve cause heartburn?
So that is a great question, and something that is still, frankly, under investigation. There are some studies that show that it can cause or worsen heartburn. And so for patients who have some element of significant heartburn when they come to see us, those patients may get further workup to determine if they truly have heartburn and what the severity of it is. And there are some subtle things that we look at in terms of there's a sphincter at the bottom of the esophagus that is related to reflux disease and how that works or doesn't work. And that may sway our recommendation, against the sleeve towards the gastric bypass. But again, it's not, I want to avoid a blanket statement because for actually most patients after a sleeve, their reflux may actually improve. Part of it has to do with the weight loss that comes with the procedure. As you lose weight, the pressure in your abdomen goes down, and so there's less promotion of heartburn with stuff refluxing from the abdomen into the chest. And so for a lot of patients, it'll improve. But we do take significant reflux seriously, and we probably would work them up to get a better understanding and then determine what the best procedure choice for them is.
Alex, anything to add?
Yeah, some patients do notice a little bit of heartburn happening after the sleeve in particular when they never had it before surgery, and oftentimes it's the behaviors around what they're eating, so carbonation, so any beverages with bubbles, so even if it's a sparkling water or pop, sometimes can increase the pressure and push that acid upwards. That tends to be a big one. Or sometimes, weirdly enough, drinking through a straw. Sometimes people take in too much air. So, but then usually once people stop, drinking bubbles or with the straw, it tends. Or if I've also seen it with some people chewing gum. If they chew gum with their mouth open, they'll take in a lot of air. It sounds very weird, but sometimes that can happen as well.
The next question, how long can I expect to wait between my clinic visit and getting the surgery? How do I plan for my procedure?
So again, that's going to vary from person to person. But as a sort of general rule, every insurance will require a certain amount of time that you undergo what's called a medically supervised weight loss program, which are monthly visits, and they're consecutive monthly visits. Some patients have that requirement waived, some patients have that requirement, and it can range anywhere from 3 to 12 months, again, depending on the insurance. We work closely with the patients, their primary providers, as well as insurance carriers to kind of stay ahead of that timeline so that there's no sort of period of time where they're just sitting around and waiting. So we try to expedite everything as much as we can, but we also don't want to minimize that preoperative period where it's important for patients to get all of their education and counseling and to really understand their lifelong commitment going into the surgery.
Sure, thank you for
A
that.
question kind of piggybacking off of this. A lot of patients ask if they have to lose weight before surgery, if there's some requirement. And again, that comes down to insurance. Some people have to lose 10% of their body weight, for instance, or they can't gain weight at all from their initial evaluation. Again, comes down to insurance. I will say from our perspective, I particularly like to see a little bit of weight loss, nothing significant, even just maintenance. I get a little alarmed when weight kind of increases quickly. Some people participate in what we call food funerals, so they'll be like, oh my God, I can never eat this again, and then they just kind of eat everything that they can, and their weight significantly increases. So sometimes we will hold up patients a little bit from that just because we want to set you up for success afterwards. So that can extend the time between initial and surgery for sure.
And just patients are obviously going to be curious in terms of the timeline and the process through the program. We try to consolidate things as much as possible. For instance, sometimes we'll do the initial medical evaluation on the same day as the dietary evaluation. The psych evaluation is a longer evaluation. It's, I think, a 3-hour comprehensive evaluation. So many times that's done on a different day. But we try to keep those things in mind so that we minimize, patient travel and inconvenience and things like that. So we've really sort of streamlined our process to try to accommodate patients and make it a sort of relatively straightforward process through the journey. Christina, I don't know if you have any
mine was sort of fast-tracked. I saw, I did my initial evaluation at the end of January in 2018. My surgery was March 20th, but I also had a really high BMI, so and I had already done my sleep study. I already had my CPAP. So I didn't really have any other issues, and so actually, because somebody had canceled on your schedule, I was able to get my surgery scheduled pretty quickly. So I know that that's not typical, so I wouldn't go by me, but that is how it worked for me. So
I think a typical patient probably would be anywhere between 6 months to a year from the initial evaluation to when surgery would actually happen. So it can be a potentially longer process for some people. I would say most people, it's a little bit longer. Yes, you are special, very. That's why you're here.
Well, the next question for Dr. Obeid, is surgery painful?
Well, no surgery is going to be pain-free.
Sure.
So we have to sort of set that expectation. But as opposed to traditional surgery, this is small incision surgery, laparoscopic surgery, which has significant advantages in terms of recovery, chances of wound-related complications, and pain control. With a traditional cut with traditional surgery, it can be quite painful, and laparoscopic surgery really has that advantage. Now, most patients, of course, we do things like give pain medication, a high dose of Tylenol and ibuprofen type medications depending on the patient around the time of the surgery itself, and we give a lot of numbing medication so that they come out of surgery relatively comfortable. But in my experience, the first 12 hours until the following morning can be rather uncomfortable. Most patients describe an upper abdominal sort of pressure / pain. That may have to do with sort of the dissection that's required with surgery of the stomach along the diaphragm. And by the next morning, that pain is significantly improved. Nausea can also be an issue in the early postoperative period. But for most patients, we get them through it without much of a problem. And frankly, I hear both. I hear, that was a little bit more involved than I was expecting, and a lot of patients saying that wasn't nearly as bad as I was expecting. But, we try to set expectations. No one's going to be completely pain-free, but in general, I would think of it similar to a routine gallbladder surgery. It's a similar type of procedure, small incision, cameras. We do a lot of numbing medication to make the patient feel relatively comfortable. The real expert in this is going to be Christine.
Indeed.
Honestly, for me, it wasn't bad. I had my gallbladder out previously. I had an easier recovery from this surgery than I did the gallbladder. I think part of that was due to the pain management plan, which was put into place and discussed, I think, at every single visit I had, whether it be with Dr. Obeid, the NP, or with dietitians. This is what the plan is, and this is what you're going to go home with, and this is what you need to be ready for, and you're going to have pain. This is surgery. So I already knew that, it was going to be that I was going to have a limited amount of pain medication in terms of a narcotic, and that I also knew that the goal was, from the minute they wheeled me into my room post-op, walk. And I did. I think I lapped that floor about 400 times because I knew, as much as it was uncomfortable, that the more I walked, the better I would feel, the sooner I would feel that go away. The most painful part of the surgery, I think, for me was the gas. That's, because they fill you up with gas and it kind of gets trapped up in your shoulders. And so, you just kind of have to roll around on each side every 20 minutes and sort of move it around. But then again, walk. And then you get to go home. But right. Honestly, that gas part was the worst part for me.
Thank you for that. So we're heading into the final 10 minutes. We still have a few questions to get. I know, doesn't it go fast?
Yeah.
So we're going to get through these questions. The next one for Dr. Obeid, what's the recovery process like? How much work will I miss with bariatric surgery?
Yeah, that's a common thing that we discuss at the surgeon's visit. So I would say it's a good bet to be off from work for about 2 weeks, okay? But your restrictions go beyond that. So I generally counsel my patients that they're, for the first month after surgery, that I would advise that they don't do a lot of heavy lifting, which I usually define as 10 to 15 pounds. because we want the wounds and everything to heal properly. And when you're doing a lot of lifting or straining, that can affect wound healing. And so that is one of the main restrictions for post-op recovery, of course, in addition to their dietary progression. But in terms of missing time from work, assuming that it's a desk job or something that's not labor intensive, then I would say 2 weeks is probably a good range. Some people may feel ready earlier than that. Some people may need longer than that, but that's sort of an average. But certainly the first week, most people are not feeling up to doing a whole lot other than just resting and recovering at home. So that's the general advice that I guide patients with. Again, Christina.
I have a desk job. I took I took 3 weeks off because I could have gone back after the second, but I was going on to not solid foods, but the softer foods, and that wasn't something I wanted to test at work. I thought, well, let's just hang out and do that at home. But I was able to do some work from home. It was 3 weeks back, ready to go.
Okay. Next question we have for Alex and Christina. How long will it take to settle at my new and actual weight? What if I don't lose all the weight I expected to lose?
That's a good question. And so this is an annoying answer, but it depends. So people with more weight to lose are going to lose a bigger amount within the first year. So we try to give patients a projected weight, based on your height and your weight and your comorbidities, where do we expect you to be after a year? A man who's 6'4", who weighs, more than a woman is going to lose weight a little bit faster. So a lot of people like to go on like Facebook or YouTube and they're like, oh my gosh, how has she lost 100 pounds in 3 months and I've only lost this? So we don't recommend doing that. So everyone's different. And as far as settling at a weight, traditionally in the beginning, weight loss is very quick, but plateaus are very, very normal, as with any other plan. So people will kind of settle a couple times and then get to a weight. It can happen, but I think with an increase in exercise or sometimes reevaluating what exactly is going in as far as calories go, sometimes people can get past that, but sometimes your body's just happy with where it's at. And usually at that time, I kind of like to focus on like, how are you feeling? And people will focus so much on the scale and they don't realize like they just, walked a 10K or they're on the, the ground with their grandkids or things like that. They're not really thinking about, and that's a huge, exciting thing.
Or they're off some medications.
They're off medications. They're not on their CPAP. There's so many other incredible things besides the number.
Sure.
Yep.
Christina, how did you discuss surgery with family, friends, colleagues?
My husband, I asked him this question last night. He said, you actually just came up to me and said, I'm going to do this surgery, which I don't think is true. But anyway, I talked to everybody and just said, listen, you guys have known me my whole life. I have struggled, I have yo-yoed, and I'm tired, and I hurt. So this is what I'm going to do, and it's going to be me being super selfish for the next year to the rest of my life, and I need to focus on me. And pretty much everybody got on board. It wasn't I didn't have anybody who was against it, or everybody just had questions, and I'm very lucky. They were all really supportive. So it was just, this is what I'm going to do. My best friend in particular was super concerned, so I sent her to the website to see the videos and sort of understand, and I think that that's a terrific resource. When you're talking about it with people who just don't understand. And, after she watched that, she was like, I get it, I'm on board. So it was pretty quick. And, I'm not asking permission. I'm telling you I'm going to do this.
That's fantastic. And as a patient, what was the most surprising outcome and possibly the most challenging part of the process?
I will tell you the most challenging part is the mental game. And anybody who tells you that this is, a quick fix, an easy way out, they have no idea. Most of us, all of us watching, are food addicts. We have addictive personalities, and there's a reason. And 9 times out of 10, it's because we're too busy taking care of everybody else, making sure everybody else is okay, doing everything for everyone. And we stop taking care of ourselves. And it's really easy to bury stuff with food. So for us to have this surgery, we have to talk about the triggers and the reasons why we're this way and how this is our coping mechanism. So, the mind game has been rough. I've always had a therapist. I was seeing her once a week for forever. And sometime around June, it was sort of like, holy cow, here comes all of the feelings, and you start feeling all your feelings all at one time, and you have nothing to do. You cannot eat. What do? It's hard. So that's been the surprising part, but it's also been the most freeing part, because you're dealing with the stuff that's really been there for a really long time. The thing that's been pretty much the coolest and surprising is finding out you have muscles in places that you didn't know existed. My husband hugging me and going, "What's that on your back?" "Oh my gosh, these are muscles," you know? So, I mean, yeah, it's been pretty fun.
That's great. That's great. The next question I have is for Alex. When can I get pregnant after bariatric surgery, and will the baby be healthy?
Yeah, great question. We actually see so many women who want weight loss surgery because with weight loss, women actually become more fertile, and so it helps women get pregnant. So we do say for the first year after surgery not to get pregnant, because you're still trying to provide your own body with proper nutrition. But after surgery, yes, women can definitely become pregnant. And really, actually, women don't need as many calories as they think that they do. The eating for two myth isn't really true. It's really only like 300 to 500 extra calories in the third trimester. So, but we work with a lot of patients who, we try to sneak in higher calorie, healthier options to get them to that level after. But yeah, definitely.
Fantastic, thank you. What if I need to have plastic surgery? Does insurance pay for plastic surgery after weight loss?
So sometimes insurance, again, depending on the plan, will. Our advice is, well, first of all, from our plastic surgeons, is they want to make sure that weight is stable for at least a year. So they don't want to remove skin from somewhere if someone's going to continue losing weight or if they might potentially gain. So I think that's one of the criteria from our plastic surgeon perspective. And then as far as insurance goes, I believe they will only cover it if it is a medical necessity, not for vanity. So, and I think only around the abdomen and if it's like rubbing. So what we recommend is if you have lost excessive amounts of weight and your skin is rubbing or chafing, like always document it, always tell your primary care so that it's all in there so you have a good case for insurance for it to be covered. Yeah.
Next question. I got a postcard saying I could get this procedure in Chelsea. Can I do all of it? Tests, surgery, counselling in Chelsea, and is it still U of M?
Great question. So the answer to that is yes for all those components of the question. So our program is University of Michigan Bariatric Program. We have offer our services both before surgery, the actual surgery itself, as well as aftercare. In both locations. The way that we generally go through the process is you can be seen for your evaluation in either location. I will say this, not all patients may be appropriate to have their surgery in Chelsea, so that's a determination that we make when we see them in the office. But yes, all the services are available in both locations, and looking forward to taking care of patients in either location.
Absolutely, absolutely. So you guys did a fantastic job. We answered every single question, which is wonderful. And we're going towards the end of our chat today. So Dr. Obeid, Alex, Christina, thank you all for sharing your time. Thank you for sharing your perspective. That was fantastic. If any of our viewers are interested in sharing today's recording with others, obviously you'll find it on our Facebook page later today and also on the Michigan Medicine YouTube channel shortly thereafter. So again, thank you all for joining us. Thank you to our viewers for all these questions as well, and have a wonderful afternoon.